Okay. Once again, good morning. First of all, I would like to thank the organization committee and the special professional coaches for this nice invitation. So to declare that I don't have any conflict of interest for this presentation. And I will start with arterial stiffness, which is defined by pulse wave velocity. And 2010, you can see here that for the first time, we had the normal carotid and femoral. These values were collected in 8 European countries. The data came from healthy participants with normal blood pressure values. And on this slide, you can see the normal values of arterial stiffness and vascular aging in the healthy population according to their age. How to define early vascular aging from carotid and femoral pulse wave velocity? How to define early vascular aging from arterial stiffness? As you can see here, when our patient has a higher percentage of damaged arterial wall than the expected from his age, then we say that we have early vascular aging. So early vascular aging is the acceleration of vascular aging, and this is a mathematical way to calculate early vascular aging. Excuse me. Using the pulse wave velocity Z score. And then we have to have in mind that early vascular aging is defined when pulse wave velocity Z score is higher than the 95th percentile. So why is it important to talk about early vascular aging? Is it useful or not? And of course it is useful. First of all, it is non-invasively way to determine target organ damages. And it seems to be an arterial tissue biomarker that may be more predictive than the circulating biomarkers and may add better additional prediction when coupled to the already known and classic cardiovascular risk scores. And here you can see the most common determinants and cardiovascular risk factors that are combined and increase our arterial stiffness. The most common are hypertension, of course, diabetes, obesity, the metabolic syndrome, smoking, chronic kidney disease. And we have to think that all these factors act together, and this is a multifactorial process, not one determinant process. And there is the tendency always to be increased, the arterial stiffness, with the age, with increase of age, even in a healthy population, without the other cardiovascular risk factors. Hypertension is the well-known cardiovascular risk factor that affects early vascular aging by its own, and especially systolic blood pressure. Sex plays also its own role, and of course the duration of all cardiovascular risk factors. There are also factors in early life, such as fetal growth, birth weight, adjusted for the gestational age, prematurity, and postnatal growth patterns that all affect our arterial stiffness. And these early life factors were found to be predictive of early vascular aging, even in the adolescent population at approximately 16 years old. And there is still an ongoing debate how these factors from early life can affect our arterial wall. And we are not yet sure, but we think that, first of all, the genetics may play its own role from the background structure, and the other role is the environmental factors that can affect our phenotype. And here I should definitely report the healthy vascular aging phenotype, which is a composite of low pulse wave velocity and normal blood pressure. This is, of course, maybe we have a beneficial profile of traditional risk factors, but still this doesn't fully explain the healthy vascular phenotype. Maybe all the genetics and environmental factors also play their own role here. And the luckiest patients who have the healthiest vascular phenotype, which is called the supernormal vascular aging, and this seems to be the more the luckiest. Sorry. So why is it important, again, to know the vascular aging? Because it has been linked not only with cardiovascular morbidity, but also with cardiovascular mortality. And here we can see that in patients with end-stage renal disease, every 1 meter per second increase of pulse wave velocity of arterial stiffness increases 39% the risk of mortality. When we add pulse wave velocity index in the already known models, which combine always age and other parameters of cardiovascular disease, we can see that the area under the ROC curve increases, and this increase is statistically significant compared to the other models, which doesn't use the pulse wave velocity index. And of course, when pulse wave velocity index is used and added to score, to the already known and well-used score, the hazard ratio is highly increased, and this difference is statistically significant. This is very important as it shows that the arterial stiffness and early vascular aging has their own role as cardiovascular risk determinants for subclinical organ damage and mortality, and of course morbidity. And here you can see the biggest meta-analysis in the field. It contains 17 studies with more than 17,000 patients, and shows that the hazard ratio when we use pulse wave velocity is 30%, shows a 30% increase for cardiovascular disease, 28% for stroke, and 23% for coronary heart disease. Having all this on mind, Vlahopoulos et al. From the Artery Society says that have concluded that carotid femoral pulse wave velocity is a very useful biomarker in order to prevent not only primary but also secondary cardiovascular disease. And this recommendation for the use of carotid femoral pulse wave velocity for risk stratification is 2A, and the level of evidence is A. After this, 2018 and 2018, the latest guidelines from the European Society of Hypertension for the management of arterial hypertension concluded that pulse wave velocity should be used for the detailed screening for target organ damages, as it can predict atherosclerosis and cardiovascular risk. However, it is important, however, they conclude that the routine use is not recommended, and it is not recommended excuse me, only for one reason, because it is not practical to have the measurement of arterial stiffness. And of course, it is not practical. You can see at this slide that we need this machine. This machine is expensive and needs a researcher that is can commonly use this machine. We need to measure the distance between the recording sites. We also need to have the time delay, or the transit time of the arterial pulse to transit between the recording sites. And after this, we have the result of pulse wave velocity, and we have to calculate early vascular aging. So the process is very difficult, and the technique is also very difficult. And it's difficult because we need a quiet examination room, we need constant temperature, we need low lead, and of course the patient should refrain from eating any food, caffeine or tobacco for at least 3 hours, so we're not sure if our patients follow our instructions or not, and as well as drinking alcohol for 10 hours before recording. Also, we need to have time in order to reassure the arterial stiffness and our measurements, as we need to have 2 or 3 measurements after the first one in order to reassure the reproducibility of our results. So we need also time. And that was the reason why at 2006 they created, Lee et al. Created the ASI, the ambulatory arterial stiffness index, which reflects arterial stiffness from simple parameters, and these parameters are age and 24-hour ambulatory monitoring. ASI has shown all these years its own value, as it has been linked with cardiovascular mortality and cardiovascular morbidity. The problem with ASI is that it doesn't take into account other parameters that affect arterial stiffness. And these parameters are, of course, age, sex, BMI, diabetes mellitus, and kidney function. All these parameters we have seen that affect our arterial wall and plays an important role on the process of vascular aging. Here, this is a publication from our team, which uses a univariate analysis in order to show the correlation of simple parameters from blood pressure measurements in order to see their correlation with early vascular aging. And as you can see here, systolic blood pressure, diastolic blood pressure, and heart rate from the 24-hour monitoring, ABPM monitoring, were significant determinants of early vascular aging, also office systolic blood pressure and office heart rate. However, in the multivariate analysis, you can see that except of age, diabetes mellitus, eGFR, only parameters from the 24-hour ABPM remain statistically significant determinants of early vascular aging. And these parameters were the systolic blood pressure and the diastolic blood pressure. When we try to see which of these measurements are important and to combine all these measurements, ABPM, home, and clinic, we concluded from the area under the curves that only ABPM systolic blood pressure was important in order to predict the early vascular aging. So after all this, we went a step further, and we used the random forest. The random forest is a supervised machine learning classification algorithm which uses the input variables in order to define splits for each node. And random forest helped us in order to create a new score. The score is called early vascular aging ambulatory score, and uses the 24-hour systolic, diastolic blood pressure, heart rate, age, sex, BMI, diabetes mellitus, and eGFR in order to predict the probability of a patient to have early vascular aging. And here you can see the gene importance from random forest with all of our variables. And the score had a great accuracy, sensitivity, and specificity at around 0.8 for each one. And here you can see how our application looks like. You can add different parameters from your patients, from your population, and finally, to have the probability score of early vascular aging. The application gives also the opportunity to upload or to download the results in order to use it in big databases, and also have the result of EVA's score. And I'm very happy to announce for the first time the external validation of early vascular aging ambulatory score. And I'm also happy because all these years, the years lost during COVID, we didn't lose the research years from our center. And we had the luck to include 8,000 patients who referred to our clinic in order to have the external validation of early vascular aging ambulatory score. The results, the preliminary results, showed that our score has a sensitivity and specificity score calculated at around 98% for sensitivity and 75% for specificity, whereas the positive predictive value is very high, 95% for positive, and for negative predictive value, 92%. Here you can see the population, the external population of early vascular aging ambulatory score. And with blue, you can see the initial population, which used in order to predict for the first time the vascular aging score. And with red, the external population. And as you can see here, even in the first population, we had a good discrimination to the compared to the general population. And this may be the reason of the good positive predictive value we had at the external validation calculations. And of course, I can't close this lecture without say two words about the other scores. We have seen ASE, we have seen early vascular aging ambulatory score, and we have other two scores, which is the SAGE and the decision tree model. The SAGE score uses clinic systolic blood pressure, age, glucose, and eGFR in order to calculate the aortic stiffness simply. The problem here is that they use clinic systolic blood pressure, and we have seen that the clinic systolic blood pressure can't reflect arterial stiffness as importantly as 24-hour blood pressure does. And finally, we have the decision tree model, which uses more than, if I remember well, more than 10 parameters in order to have a tree and say finally if we have early vascular aging or not, if we have our aortic stiffness or not. The problem here is that they use some parameters that are difficult to have in the daily practice. For example, the carotid plaque. Of course, not all of our patients have ultrasound. However, it's still another score we have for our clinical practice if we don't have the possibility of the machine to calculate directly aortic stiffness and arterial stiffness. So to conclude, arterial stiffness is a marker evaluating hypertension, target organ damages, and cardiovascular risk. The new scores could be used for cardiovascular risk stratification. And of course, we should have extra research and evaluate these scores for their performance on other hypertensive target organ damages, as well as to be compared with ASI and other cardiovascular risk scores, such as the SCORE and Framingham. And finally, in the future, the prediction of VIVA could be used, and we hope that it will be used to guide early lifestyle or pharmaceutical interventions in order to prevent future cardiovascular events. So thank you very much for your attention, and don't forget that we are all as old as our arteries are, so don't forget to grow younger. Thank you very much.